Checking, please.
So you might need to start.
Okay. I'm ready. Okay. Shall I start?
Yes.
Okay. Hello, I'm Dr. Hindawi. I'm one of the registrar. May I confirm your name and age, please?
Hello. Um, I'm Amanda Jones and I am 36.
Uh, okay, Amanda.
Yeah.
Amanda, I understand you're here today to meet the consultant and discuss regarding your plan for delivery. Is that right?
Yes, I have been waiting here for 2 hours now.
I'm so sorry, Amanda. I know that it's really not, it's nearly not intended to keep you waiting all this, but the consultant has been pulled out for an emergency, and I'm here on his
You're not
behalf.
even the consultant.
I know I'm one of the registrar. I'm so sorry. I know you expect to see the consultant today, but he was pulled to an emergency. We thought he would finish earlier and come and see you, but it looks like it will take longer than we expect. So that's why I'm here to discuss with you, if you don't mind. Otherwise, if you're still not happy about our conversation today, we can arrange another appointment with him later, if that's what you wish.
It's okay. So
Okay.
what do I do? Yeah, I'm here. I'm here. They called me and they said that you need to see the doctor.
Yes.
Yeah, after my scan. So I don't know why.
Okay, I have your scan report here and we will go through it. But before this, do you mind if I ask you a few questions just to know you better? If that's okay.
Yeah,
Okay, how is your pregnancy so far?
it's okay.
Okay, and baby movement is good?
Yeah,
Okay, this is your third baby, isn't it?
yeah.
And could you tell me how was the delivery of the first two?
Um, I just got some pain.
Mm-hmm.
I went to the hospital. Everything was fine.
Good.
Yeah. However, in the last one, I think the shoulder stuck
Mm-hmm.
the baby, and then it was quickly, and they put it to the edge of the bed, and then it's fine. I just delivered.
Okay, so both of them was a vaginal delivery and the last one had a shoulder dystocia.
What?
So both of them was a vaginal
Yeah.
delivery.
Yes, it was a vaginal delivery, but I don't know what is the last one. Yeah,
Okay,
this
you said,
shoulder
oh,
stuck.
okay. So sorry, yeah, this is shoulder stuck. It's called shoulder dystocia. I'm sorry.
Okay.
Yeah. Okay. Otherwise, the recovery was okay.
Yeah.
Okay. Do you have any other medical problem away from the diabetes?
Nothing.
Okay. Have you had any surgery in the tummy or down below before?
No.
Any allergy?
No.
Are you taking any medication on a regular basis other than the insulin?
No.
Okay. Do you smoke?
Sometimes.
Okay. Have you ever considered quitting?
A lot, but I'm not able to.
I
Anyway,
know.
that's
Mm,
because the kids um they're at school and the pickup time is now it's going to come soon. So
okay.
what's in the report, doctor?
Okay. So I can see you're here today alone. Do you want to call someone to be with you? Because I'm afraid I have some concerning news to discuss with you.
What concerning news is that?
So the scan report show that the baby is growing on the higher side or more than what we expect. Okay, this can happen if you have diabetes underlying. If it is the diabetes is not controlled. Your last blood level shows that the level of blood sugar, is higher than what it should be in the pregnancy.
So you think that my baby is getting big? That's because of my diabetes?
Yes, this is one of the complication of diabetes.
How big is my baby?
He's 4.5 kilograms so
Oh, it's
far.
fine. I delivered the last one and it was, I think, 5 kg. It's fine.
Okay. I understand that you have two to vaginal deliveries before, but you said that the last one got stuck, and this we called this as a shoulder dystocia. With the diabetes, the risk of having this shoulder stuck or shoulder dystocia is getting higher, and especially if you have this before, then the risk is coming higher. Shoulder dystocia, as you see last time, usually we have a lots of maneuver. It's an emergency, kind of emergency, where you find a lots of people rushing to your room. And we have a lot of maneuver where 99% we will deliver the baby safely. However, there is a risk that the baby may get really stuck, and this can cause a permanent injury in the arm, and cause the paralysis of the upper arm of the shoulder that's stuck. And also sometimes if the baby is not easy or delivered on a reasonable time, this can cause a cut down of the oxygen supply to the brain, which can cause permanent brain damage. I know this sounds scary, but because
Yeah.
of the seriousness of the complications that could happen when shoulder dystocia happen, we have to discuss with you the other options about mode of delivery.
Oh God. You're telling that my baby can have a brain damage?
There,
Are you
it's a risk, and unfortunately, the diabetes increase that risk as well. So when the baby reaches 4.5, we don't, and with diabetes, we don't really recommend a vaginal delivery, especially with such a history before,
So
because
I would control my blood sugar. I promise. I promise. I will control my blood sugar.
okay, I really understand. We have to help you to control your blood sugar. This is definitely for your health and decrease the other complication of the pregnancy and on your health as well. This is really mandatory. However, for the delivery, unfortunately, this is too late because the baby is already big. He's not gonna get smaller. You get my point?
Yeah, but you said 4.5. I think it's okay. From
Well,
now to the time of delivery, I don't think that, um, I'm
it's
only 37 weeks.
Yeah,
So
I know. But with the diabetes, 4.5 and above is not okay with the diabetes to have a vaginal delivery. The risk is really high. Whatever your concern, whatever your decision, we will support it. But just I'm here to let you know
what is
what
the
is
other option
the
of?
advices. Yeah, the other option is to offer you a cesarean section, which will be safer in your situation. I know this cesarean section can be it's a major operation. However, this is a safer option in your situation. It will
So
be done
that's
by the best hand. Okay.
so you say that the cesarean is going to, it will be much safer.
Yes, because we will avoid the risk on the baby. However, it's like any other operation, it still carry some risk, including bleeding, infection, injury to the nearby organs, like bowel, bladder. The recovery time is longer, and the risk of developing blood clots and legs and lungs can be a little bit higher. However, we will assess your risk and see if you need a blood thinner. We might give you a blood thinner for some time after the delivery to prevent that. But in such situation with abnormal, with big baby or large size baby, and the fluid around the baby has increased as well, and the diabetes underlying is not controlled, the
You
safer
fluid,
option will be a cesarean section.
you should fluid around the baby's skin. What is this?
So the nose fluid around the baby is again because of uncontrolled diabetes, it's slightly increased. So it's just above the normal. It's not too much, but it's just above the normal. But with uncontrolled diabetes, it can get more and more. And this can put you also on another risk of rupture. The brain can get rupture and broke your water. And this can lead to the a cord come first and slip because the baby will not be well engaged down in the pelvis. Is that,
Oh,
is that clear?
yeah, it is. So I think that I need to discuss this with my husband.
Of course,
Uh,
I
and
understand that.
yeah, and when will be my cesarean?
Okay, so we will do it as soon as possible, but we need to adjust to your diabetes level, sugar level, blood sugar level, importantly to help in the recovery of your
Okay.
wound. Okay. You argue too much.
Believe me, you can't imagine how the role player in the exam. If you meet her, okay, in the exam, you will know that I'm very kind and letting you speak and continue one word of what you say.
Okay.
So, okay, so the patient, she's asking questions, and I think I
And
covered most
join
of the
Rabbi
questions.
if you're free.
Hi, hi, dear. So,
Mm,
uh, Dr. Hind,
yeah,
you did well.
thank
Okay.
you.
Yeah, I think it's very well, mashallah.
Mm,
Um, you have managed the communication from the beginning, which is correct. Okay, the patient was waiting for 2 hours and she was not happy about the waiting time. So apology for the waiting time is a very good approach,
mm,
actually. To start your station. Also, explanation that you are not the consultant. That's very important.
mm,
Okay, and offering her the another appointment if she would like to. Okay, then the patient allowed you to continue your role.
mm,
So you have just to start, of course, with the information gathering, which is a good choice,
mm,
because otherwise, in such patient, you will not be able actually to continue your history taking after discussing the report.
of course.
In your history taking, I was happy that you didn't ask her about the diabetes. Um, when was the last time you've seen your doctor? Have you done
Mm,
your eye check? Have you done your kidney check? Uh, I was happy that you
mm,
didn't ask those questions in the past,
mm.
okay? Because actually we are here today to discuss the situation of the
Dr.
decision of
Lee.
the she's already 37,
Mm,
okay? And none of these questions is going to help you.
yeah.
Okay. You have managed to ask about the medication, the allergy things and all, okay, which is important. Um, Even discussion of would you consider stop smoking at that time?
Mm,
Yeah, I know that it must be there
mm,
in the list, but you can keep it to the management, okay? Especially that she said occasionally.
mm,
Okay. So now we come to the point of the discussion of the report.
mm,
I would like to remind you, my dear,
mm,
with one
mm,
thing, okay?
mm,
So remember when we agreed that we have to divide the station into three parts?
mm,
The first part would be for the introduction, setting agenda, and
mm,
the information gathering. Second part is for if there is a report like this, you will discuss the report.
mm,
Okay. And thirdly is the management, explanation and management, right?
mm, mm,
So when you discuss the report, I need you please, whatever in the report, you need to
mm.
cover it one by one, okay? So
Okay.
this ultrasound is done,
Mm,
okay? And it showed that the gestational age is 36. Okay, she had already the ultrasound
a
before.
week ago. Yeah.
Yeah. So and it showed that the baby is good. Okay, and the head is coming first. Okay, and after birth is coming. It's away. Okay,
Mm,
from the neck of the womb, and it's to the front. Okay, so
mm,
up to the water around the baby, and you
mm,
explain that the water around the baby is slightly increased than what is expected. Okay.
Mm.
So you come to the baby weight and then you explain the baby weight according to the age. Okay. So
Mm.
here, when
Mm.
you speak to her about that the baby is big, here you need to explain
That
that,
first.
yes, what is the meaning of the 90th centile. Okay.
Okay.
So yeah, so it's what is the meaning simply?
So this is the normal, this is the chart that show what's normal for you. You have these two lines. The baby, normal size baby, which is normal for you, will be between these two lines. However, your baby is on the higher side of that line, which means that the baby is big for you. It may be
Yes.
normal for someone else, but for you, it's big.
Yeah, and also that's mean her baby is one of the, if you have 100 babies, okay,
Mm.
at gestational age, so her baby is one of the largest 10,
Mm.
okay, out of that 100. So this would be like the full explanation of the report.
Okay.
So whenever also you have investigation in the exam, like
Mm.
full blood count, okay, you have
Mm.
to comment on the full blood count,
Okay.
okay? Whenever you have full blood count is normal, renal function is normal, the coagulation profile is normal.
Mm.
I need you to explain the investigations, okay, including the normal ones, right? Because the explanation of the report, usually there will be like all the items,
Mm.
it will be written there in the tick boxes. So if you focused only on the abnormal thing or
Mm-hmm.
the most significant, unfortunately, you will not complete
Yeah,
the
the rest.
required, right?
Okay.
Also, when you come to the explanation,
Mm-hmm.
okay, you say the report,
Mm.
okay, then let her, okay,
Mm.
ask you questions about the reason for that.
Mm-hmm.
Okay, so it's like again, it's like a game, okay, and you have for example, the tennis, for
Mm.
example, okay,
Yeah.
you have to give her the ball,
Yeah.
right? Give her a chance to ask you the question, and then she will, she
Mm.
will, and so on. So this is like the two ways conversation, right? It's like we are now experts, okay, and the exam is just it's a role player, and it's an acting thing. So she had to do her roles, and you also do your roles. So
Mm.
finish the report, just the point of the finishing report and explanation on what is concerning in the report, okay, and then let her ask you the question about what is the meaning of that. I think there's no problem, and she will do her acting thing, right? Okay.
Mm-hmm.
So when she come to the point of that the baby is not big, okay, and I've delivered the 5 kg baby before,
Mm.
even in the exam, the role player, she said to the candidate that I am big. My husband also is tall, and
Mm.
so that's mean she had no problem. Okay, so it can be right,
Mm.
right. But the problem with the diabetes, as you said, that the risk that the shoulder will stuck and so on. Okay, again, please avoid any jargons.
Mm.
Okay, again, even in your daily practice.
Mm.
Okay, avoiding jargon. If the patient accept the patient is well educated, she understand what you say. Everybody now is aware of the medical terms, but we don't know which type of patient you will have in the exam, and this is an exam,
Mm.
right? So there will be one lay examiner there, okay?
Mm.
He's sitting there, and like an old British lady, and they will always all due respect, and she's
Mm. Yeah.
saying, okay? So she will mark you down. So avoid it, okay?
Okay.
So this is the things about the marking sheet. Okay, a few point only, as I told you, that you need to make it better, inshallah, and
Mm.
otherwise you pass the station. So
Okay.
thank you very much. Don't forget about the admission,
Okay.
okay?
Of
Because
course.
the time, it was about the time management, I
Mm.
know.
Yeah.
Okay, so your time management was good. However, a little bit,
Yeah,
maybe
I still need to give
rather,
her the leaflet as well and the
yeah,
consent. Yeah.
it's like 20 seconds,
Yeah.
was more needed. So guys, please, unless you have a question, please make sure that your mic is muted. Okay? Please, okay? Otherwise, please make sure that your mic is muted. Thank you.
Okay. Thank you.
Thank you. Okay, so
Dr. Abab, Assalamu alaikum.
Walaikum salam wa rahmatullah. Hello, Dr. Suzanne, how are you?
Alhamdulillah. In this case, because I joined late, in this case, we will offer here the three options: induction or cesarean or conservative or waiting.
No, actually, we will not offer her the waiting, okay,
Mhm.
because she is diabetic, okay, with complication. So whenever we have a diabetes type 1, okay, or a pre-existing diabetes, type 1 or type 2, and an exam, and you want to discuss with her about the time of the management or the delivery. If it is complicated, the time of the delivery should be, by the 37 weeks. She's already 37 weeks, yes. So that's mean we need to do something then.
So
When we come
and
to
regulate the sugar. Admit here, and the diabetic
yes.
doctor will see here, regulates the diabetes and induction.
Yes, but we are not going to go for the induction as a recommendation because this patient had a previous history of shoulder dystocia, right? And she had polyhydramnios already, and she had a big baby plus the diabetes. So putting all together, her risk is very high. Okay, the diabetes itself, it increases the risk of the shoulder dystocia, previous history of 4 times, and previous history of shoulder dystocia, also that's 10 times increased. Okay, so this is very big risk, very high risk. However, we have to give her the choice.
Because I joined late, I think she is the low risk, nothing. So
she is a high risk patient.
So if low risk and nothing, no in her history or examination or diabetes, we offer for her the 3 options.
Yes. But remember that the patient with uncomplicated diabetes, no fetal, no maternal complication with the diabetes, pre-existing diabetes, should be delivered by this also after the 38. Okay, between the 38 weeks and maximum 38 plus 6. Because the timing of delivery will be asked in the exam. Okay, the role player is going to ask you about the time of delivery. Okay, and you should follow as per the guideline. Okay, about the diabetes, complicated or not complicated. Okay, if there's a gestational diabetes, we will leave her to 40 weeks.
Okay, thank you, Dr.
You are welcome, my dear. Okay, so one question to Dr. Hind. Dr. Hind, my dear, what do you think about the steroid in this case? Is it indicated?
That was my next thing to say.
Yeah.
I know that now I will discuss with her the post-steroid because now after 36 week, the guideline is not clear about giving the steroids, and after 37 weeks, this is the cesarean section again. It's debatable. So I was gonna discuss the risk with her and see what she want to do.
Yes, excellent. And the most important thing about the steroid in the case, okay, that the guideline also advised, okay, that you discuss with the patient about the pros and cons of the steroid, especially with the diabetes. Why? Because when you give her the steroid injection, okay, for the lung maturation, what will happen is it's going to increase her blood sugar. Right?
She needs to be admitted and have a sliding scale if she's going to have a steroid, of course.
Yes, of course. Okay, so this is another point. Okay, this station is a repeated station and it appeared in 2021, 2022, and so on. Okay, so the station at that time, okay, was only about the discussion of the lung
maturation.
the maturation and that she need to be admitted to control her diabetes or optimize her blood sugar before the surgery, right?
Yeah.
But now after the guideline, okay, there is an extra point, okay, that you
risk
give
of autism. Yeah.
Yes. Okay. Risk of the especially with the diabetes. Okay. And risk, it's actually not the risk. It's we don't know about it. Okay.
Yeah.
We really don't, have the enough
Answer.
information or the enough recommendation to say that to the patient. Just tell her that's up to you.
Yeah.
Okay. So if the patient most likely, okay, because she told you that she's going to discuss this with her husband or something. Okay, most likely she will not take the decision,
Yeah.
right? But you have to do your role, and you have to show the examiners that you are updated. Okay, that now we give the patient a choice whether to accept or not for the steroid injection. That's it. Okay.
Okay.
So
Thank you.
question. And actually, it's an important point.
It's a
before
safety point. Yeah, it's a safety point.
Important point before we go. Yes. Thank you
Sorry?
very. It's an important point.
Oh, okay. Yeah.
Yes, because you are my special volunteer. Okay, of
Thank you.
today. Okay, you are going to get another station.
Okay, thank you.
Okay, you're welcome. And this station as well is one of the repeated stations. Okay, that I'm going to discuss with you. And
Okay.
yeah, people and find it like a bit tricky, but it will not be tricky for you.
Yeah.
Hello, good morning, Dr. Abba. Can I ask you one question?
Yes, sure, my dear.
Dr. Abba, earlier we used to say that we can increase the dose of insulin and monitor the patient and can give the steroids. So what shall we say something like this?
No, it's about the counseling. Okay, the update in the guideline in the GTG. Okay, it's about counseling the patient about the risk and benefit. Okay, of receiving the steroid. Okay, and let the patient choose, especially the patient who is diabetic. Okay, so the patient completed already 37. Okay, so the need now of the steroid is not that much. Okay, because the guideline states now that the most benefit, okay, will be before the 36, right, or up to 36. So now
earlier they used to say like
yes.
before 39 weeks we must give steroids and then go for cesarean section.
So now it's not about must, it's about counseling the patient about the risk. Let her take an informed choice, So it will be hers, it will not be ours. Okay. So now we will not recommend, now we will consider and counsel. Okay. This is a fetal lung maturation. This is an injection for the fetal lung maturation. Okay. However, you have completed the 37 weeks. Okay. And your baby is having, is big enough. Okay. But still there is a risk. Okay. That the baby gets some breathing difficulty after the delivery. The injection is going to help. Okay. With that. Okay, and it will help for the fetal lungs to become more mature and strong. Okay,
especially cesarean section.
Sorry?
Especially for cesarean section.
It's
before
only cesarean section. If it is normal delivery, no need for the steroid at all. But if we get the decision that the patient agreed for the cesarean section in this case, okay, then we have to let her choose whether to take the steroid or not to take it. Okay, especially that the steroid also, it has another problem with her. It has another maternal risk that about the control of the blood sugar. Okay, so it's going to increase the blood sugar, which we might need more control. Okay, or might need increase of the insulin dose, and this will be discussed with the diabetic doctor. Okay, but the most important thing here, my dear, the concept, because it might come in another station, not only this station. Okay, it's when you have now about the steroids, you have elective cesarean. Okay, the elective cesarean from the 37 weeks. Okay, nowadays, still you will consider the steroid injection, right? But you will give the patient a choice. This is This is what came in the guideline of about the use of the corticosteroids, right?
Okay, ma'am.
This is the only
Okay, so this,
message we came from
okay, ma'am.
that we get from the update of the guideline.
Okay, so this is for diabetes mellitus or for GDM also?
For anyone.
Okay.
That's for anyone. But we have to counsel now about the benefit and risk. Okay? Let the patient choose.
Okay, ma'am.
That's it.
Clear, ma'am. Clear, ma'am. Thank you so much.
You're welcome. Okay, so the next task is for Dr. Hind as well. Okay. So, Dr. Hind, this is a structured discussion, and your 2 minutes is now starting. So, please take your time. There is another page.
31. Okay, the next page. Okay. Can I see the first one?
Okay, so you might need to start.
Okay. Hello, is this Dr. Halford?
Hello, good day.
Hello, yeah, hi.
Yeah, it's please introduce yourselves.
Hello, oh, sorry. Hello, because he said start with Dr. Halford. Okay,
Yeah, nobody.
okay. Hello, I'm Dr. Hind, one of the registrar in labor ward. Is it Dr. Halford?
Yes.
Okay, Dr. Halford, I'm sorry to bother you at this time, but I have here one patient which I need to discuss with you. Is that okay?
Yeah, what's wrong?
So, I have a young lady. She is Catherine Hegel, 31 years old, and she is gravida to para 1, 29 weeks, and coming with a preterm. She's in preterm labor. She has a history of one preterm labor. The first baby was delivered at 31 week, and after PPROM, after rupture membrane at 31 week. And now she's coming contracting, and the cervix is 2 to 3 centimeter dilated, well effaced. We have done a fibronectin test which came back positive. There is no leaking or bleeding found on an examination. The CTG is done and it's normal. Her observation are completely normal regarding her blood pressure and heart rate. However, we done an ultrasound which show a single baby in a breech presentation. The placenta is good, posterior away from the os, and amniotic fluid index is normal. I have spoken with special care, and they are not. They unfortunately doesn't have any place available. So.
What do you want to do now?
So basically, we have inserted the cannula for her. We will take some bloods for a full blood count, CRP, liver and kidney function test, just to see the inflammatory marker. We will start her on some tocolysis to give time for steroid. We'll give her the first dose of steroids, and the second dose, if she didn't go into labor, will be in 12 hours. And we'll give tocolysis to try to postpone the delivery until the steroid work. Because she's already dilating and contracting, if the contraction didn't stop, then I will need to give her some antibiotic. And after ruling out her allergy, and which is a broad spectrum antibiotic. Usually we give, according to our guideline, according to our policy, we'll give the penicillin, metronidazole, and I will start her on magnesium sulfate, the loading dose and the maintenance dose. Because of there is no cots available, I will see her progress and start to contact the nearby hospital. And until then, if she's not progressing, we will do an in-utero-transfer. If the contraction subsided and she's no longer in active labor. However, if the contraction continue or she start to dilate more and progress, unfortunately, we will have to deliver her in the hospital and then transfer the baby after delivery. The problem now that she is breech, as I told you from the scan. So we're gonna discuss with her about the breech delivery and the risk of head trapment, especially with such a um, preterm, and give her the options for vaginal delivery or going for cesarean section. But in case she choose to have a cesarean section, I think you will need to be coming around. Do you have any
Okay,
questions?
so okay, so do that, counsel her, and if she wanted the cesarean section and it's ready for delivery, call me.
Okay. Is there anything else you wanna recommend for her, or you wanna me to do for her?
No, you have a good plan so far.
Okay, fine. So I'm gonna keep her on a continuous monitoring, continuous CTG. I will admit her to the labor ward now, give her the medication for the preterm labor, and keep her under close monitoring. And we will start to contact the nearby hospital. I'm gonna give her the leaflet for the preterm labor and the risk
You
of
are going to,
breech.
so you are going to contact the nearby hospital, and are you
Yes,
going
try to
to,
find a cot and a place in the labor ward as well, because it has to
okay,
be.
so you are going to contact it by yourself?
No, I will ask the SHO to contact, because I have to take care of the labor ward. So she can start, and the midwife can put that on the website. That's responsible for looking for a place in the nearby hospital for her, and
Okay,
then we will contact the labor
okay,
ward and find if there is a place available for her.
okay, so whom are you going to contact in the other hospital?
We on the website they contact the cots, they'll find where is the available cots, and then they will I will give the details and the number to you to contact the consultant, because it has to be consultant to consultant referral. So I will get you the contact to speak with him for the labor ward and for the pediatric, and then I will ask our pediatrician to contact the cot in that hospital.
Okay.
Okay.
Okay, so whom is going to escort her?
Sorry.
Who is going to be with her?
You mean here in the hospital or during the transfer?
The transfer.
So during the transfer, one of our midwife can go with her. Um,
So
uh,
what are the necessary equipment that will be in the ambulance?
so it will be um, So a labor set should be there, just in case she delivered, and centometrine just to give her because of the risk of postpartum hemorrhage, so for active management, and a cord for the baby, and a cot for preterm labor. One of the nurses of the special care can go with her as well to take care of the baby if he delivered earlier, just to do the resuscitation and the bag to contain the baby and keep him warm until they reach the hospital. But of course, if there is any risk, I would suspect any risk that she would deliver over the road, I wouldn't send her.
Okay, so is there any other medications that require in the ambulance?
The magnesium sulfate, she will go with the maintenance of the magnesium sulfate. It will continue through her way. So we'll give her the loading dose and we'll start hers on the maintenance. It will be continued until delivery.
Okay.
And the antibiotic, of course, will be given on a regular basis. And if the second dose of steroid wasn't given, it will be given as well. Keep her on the autocolysis if she's still contracting. Otherwise, I can't think of anything else. Do you have any recommendation?
No, just want to ask you
Yeah.
about the progress, your decision if this
Mm.
patient progressed now to 6 a.m.
Okay, so if definitely I'm not gonna send her, and will arrange an extra transfer for the baby after delivery, and I will call you to come to be around. If she's decided to go for a vaginal delivery, I'll have to be there, delivering the baby, and the pediatrician should be there to resuscitate the baby once he deliver. There is a risk of head trapment because of the small baby. So she'll need a continuous monitoring in delivery. Antibiotic and magnesium sulfate should be given. We're not going to interfere or augment her labor by any mean. We'll just leave her to do it on her own. Then after delivery, then we will give her active management of third stage of labor, give the baby to the pediatrician to resuscitate, monitor her, keep her in HDU, continue antibiotic if there is any suspicion of infection, and treat sepsis if there is any suspicion of infection. Keep an eye on her bleeding in the postpartum because there's a risk of postpartum hemorrhage. And again, continue, of course,
Patient,
magnesium sulfate
so if this
throughout the
patient is
labor. Monitor her urine output.
okay.
No, sorry.
So your patient is delivered now,
Mm-hmm.
and the neonatologist attending
Mm-hmm.
says that the baby had a good APGAR score.
Okay,
However,
good.
however, you don't think so.
Mm.
So what's your decision? Because a neonatologist said that no need for the extra transfer.
Okay, so I will contact you and I will speak with a head of midwives, a head of yes, midwife in charge, and discuss with it, and then we will discuss. We can contact the pediatrician consultant on call and discuss with him.
Okay. So that's exactly your time. Thank
Okay,
you.
thank you.
So what's your feedback?
انا حاسه اني نسيت حاجه بس مش عارفه ايه. انت كنت بتحاولي تزقيني اقول حاجه بس انا مش فاكره ايه. Sorry, I can't remember. Sorry, sorry, I don't speak in Arabic. I can't remember. I feel that I forgot something, but I can't remember what is it.
No problem forgetting anything, but
Mm.
what about the station itself? I know that the nature of the station is a bit weird.
Yes, usually the preterm labor comes in simulated patient task rather than a structured discussion. I haven't done it as a structured discussion before.
Yeah.
Generally, I think I have managed the preterm labor. I tried to be safe as possible. I called the consultant. I asked him to attend a cesarean section if we have to do it. I discuss with the patient the management and give her the options. Vaginal delivery is slightly tricky in such situation, but it still can be an option, especially the baby is large. The main problem here whether to send the patient to another hospital or keep her until delivery. So it's again it's a variable situation which can be
So,
done. Yeah.
yeah, so if I ask you about the what are the parts, okay, or the we tested in this station, do you think that this station was only about the management of preterm labor?
I mean, there was a hidden agenda. I didn't find the
No, no,
information there.
it's not about
Oh.
the hidden agenda that the examiner, okay, in such a station, they focus on
No,
the
the SPAR tool, how to inform the consultant as well about the situation.
use of the SPAR tool.
Yeah.
This is one thing. Another thing, it's about the in-utero-transfer, arrangement for the in-utero-transfer.
Oh, okay.
So,
Yeah.
so this station is heavy with communication with colleague,
Okay.
right? Along
Yeah.
with the management of the preterm labor, right?
Okay.
So, do you remember the the college videos about use of SPA?
Yeah.
Okay, so in use of the SPA tool, you have to be more specific. Okay, and I know that the station has started with you start the consultant or you start your with speaking to your consultant. Okay, technical point here, Dr. Hind. Okay, otherwise you might find yourself lost in that task at the beginning. When you start any structured discussion, start by introducing yourself, okay? And you are one of the exam candidates today, okay? The case, and I'm ready for discussion. And that stop, okay? Pause for a few seconds. The examiner will add something to you, okay? This point that the examiner will clear to you before starting the station may save you in the station, okay? Why? Because the examiner is there. He had experience with the station. He had, some candidates maybe before you, not specifically on the same day, maybe in the previous exam. He had experience and he understood that there is some point that might be not clear for the candidates about how this station is going to be and so on. Okay, so he's helping you here. Okay, the input from the examiner at the beginning of any structured discussion is very important. Okay, usually what will happen is that the candidate will go into the cubicle. They have they will be very tensed. Okay, the stress level is very high. Okay, the adrenaline is rushing and they don't hear anything at the beginning. Okay, so just try to cool down, okay, control your nerves and have a good communication with the examiner at the beginning of the structured discussion and wait till the examiner tell you how it's going to be. Okay? Okay. So here it's once your consultant is at home, okay, and you would like to call him. Once you enter the cubicle, the examiner is going to ask you to speak to your consultant over the phone. Okay, so there is a consultant and there is an examiner. Okay.
Okay.
So yeah. So when you start, okay, you will have the chance, okay, to introduce yourself, and the examiner will have the chance to explain to you. Okay. So this is about the case. Okay. And now I'm asking you to call your consultant. Please tell me how are you going to make this call. Okay. So when you start your call, okay, you will introduce yourself, but start like any call, okay? But the call should not take like more than 1.5 minutes from you, right? And then you finish your call, okay? And then the examiner will start to ask you about what are you going to do now, okay, in the hospital, about your arrangement, okay? So this is how the station will be, okay? So it's just...
So I wouldn't discuss the management over the phone, you mean?
No, the
Okay.
examiner questions. But anyway, no problem, because believe me, I know, okay, that examiners have the experience of this, and they know that the candidates will be a little bit lost within the scenarios.
Mm.
What is the situation, what I'm going to do now, and they are under pressure, okay? Most of the examiner is going to be very helpful, okay? But if you have one examiner that is tough, okay, he will not be, helping you so much. So avoid this. Just do the things that you need to do, the technique. Start by introducing yourself, then pause, okay? Wait for the examiner to speak. We give you instructions. Follow these instructions. Some of the examiners, by the way, okay, they feel, especially the old school, okay, they feel that you don't listen to your seniors, okay, that's make you, not a very good candidate.
Okay.
Right, especially those, who are, with much experience, older in age.
Yeah.
Okay. They think, yes, they think that they don't respect the seniority like this.
Yeah.
Okay. So just to give them the chance to speak.
Just
Okay.
because it said start with it is Dr. Halford, so I thought that I should
I
go
know,
and
wallahi,
start
this
the
is one of
talk,
them. Yes,
and
this
they
is
said
one of them.
before someone said before that when they go in the cubicle they found that the consultant assuming that they have a phone and they start to talk straight away. So I took it from this point and I was going to, is it Dr.
No
That
problem,
was
no
my
problem.
plan. Is it Dr. Halford? Yes,
Every
I'm
time,
Hind, one of the
yeah,
registrar. So I
never.
was going to do it in a reverse way, but anyway, it's fine.
Yeah, I'll tell you, one of the candidates said that once he entered, okay, there was a phone.
Yeah.
Okay, a real phone. So it's, the acting thing. Yes, I know
Yeah.
this sometimes funny. Okay.
Mm.
Just give yourself a chance,
Okay.
okay, to understand which type of examiner is there.
Mm.
Okay?
Okay.
Because I know somebody who did like you, okay, the examiner was trying to stop her and she was feeling like, oh my God, what did I do? Blah, blah, blah. Okay. And things, at the first 2 minutes, it took from her like 2 minutes to understand the situation. Okay. So after you finish your call, okay. So say that, okay, now I finished my call. Then be ready for the questions. Okay.
Okay.
This part you have to be more specific in this part. Okay. So how you're going to be more specific. First of all, what is the situation here? I know, okay, that you have mentioned the patient name and her gravida, okay, and you mentioned things about the diagnosis of the case, but the main problem, which is the unavailability of the cots, okay, it should be in the situation, because this is a situation. Why are you calling? Okay.
Okay.
So she had, I think her name was Catherine. Okay,
Yeah.
Catherine. Okay, so you will identify the patient by name. Okay, and the reason for your report or for your call. Okay, describe your concern, and you will mention that she's diagnosed with threatened preterm. Okay, and requiring intrauterine transfer. Okay, due to the NICU shortage. This is the situation. Okay, then you come to the background. Here you mention about the patient background, including, of course, there is any current problem or medical problem, okay, and the admission, diagnosis, the time exactly when she came, okay, and there's any significant post-obstetric history, okay, if she's on any medication, any allergies known, okay, or any laboratory result that came, that will come, okay, in the B. This will cover the information gathering. This is the background. Assessment, okay, is your assessment for this patient, okay? So what have you done for the assessment, including, again, go for everything systematically, right? So assessment will start from head to toe, okay? So the patient had the complaining of labor pain, the physical examination started from the vital signs, the contraction pattern, okay, as per abdominal examination, as per vaginal examination, okay, and the ultrasound report. This is in the assessment, right? And then you give your recommendation, okay? So your recommendation, be specific about the request and the time frame, okay? So this is very important. So what you need from the consultant, okay? The patient like this, she's high risk, breech, okay? You are arranging for in-utero-transfer. Don't hesitate to ask the consultant to come. Why not? Right? Even in real life, sometimes you feel like this is what we all did actually when we were working as registrars, okay? You're calling your consultant. This is what we used to do. That I want to make my consultant more comfortable. I want to show that I'm a good leader. I'm in charge, okay? So if you وراك رجالة يعني. Okay. So don't try to be like this in the exam. In the exam, be more conservative and more safe. Okay? So
he should attend even if it is a vaginal delivery.
not in the vaginal delivery, but for the arrangement of the in-utero-transfer, because the main point in this station, okay, that it's about the arrangement of the in-utero-transfer. It will take like more than 5 minutes of the station asking about the arrangement of the in-utero-transfer. Okay? So for the in-utero-transfer, it's a consultant to consultant,
communication.
Communication. So what are you going to do? You start by yourself. Your role is you are going to speak to the midwife in charge. Okay? And she is going, okay, to find out from the either, as you said, the website or number, okay, then for the one or who is responsible for arrangement of the transfer, okay, asking also the arrangement for an ambulance, okay, for this patient and all, okay. So who will do this job of the first communication? This will be the coordinator midwife. She will find the nearest hospital with available cots. Once she named the hospital, okay, with the available cots, then you will start your part of the arrangement of this. It's not only about the consultant to call the consultant or communication with the consultant and neonatologist in the receiving hospital, but it's also about and he is very important, okay? Your role with the patient. Don't forget that there is a patient waiting. Okay? Patient counseling and consent.
Yes.
Okay, that's very important. So the patient must be updated with the situation. She's aware of what the situation is going on, okay? And you discuss with her about the
preference, her preference, yes.
Yes, her preferences, including
of course.
including in the extreme preterm, including the chances of survival of the baby. Okay? That's very important. Look, my dear, do you remember Oxford book? There was one task about extreme preterm and
yes, it is 23.
Yes, the main 2 point in the communication with patient, okay, was counseling, including the risk of the preterm and chances of survival, okay, and about the consent of the in-utero-transfer. Maybe somehow, okay, the patient will refuse your plan, right? And you know that you must take a written consent from her. So it's very important that you explain to the examiner while you are managing the clinical part, you're also, okay, covering the communication with patient part.
Yes.
Okay. So this is one point that I will really like you to do it. Okay. Then when it comes to the arrangement of the in-utero-transfer, okay, so there is also some communication in between two hospitals. Okay, so first the consultant's going, the coordinator midwives, okay, is going to find a nearby hospital with availability of cot, right? Then you start contacting this hospital, okay? You need your consultant to contact first the neonatologist, right? The neonatology consultant. The neonatologist consultant, okay, if he accepted the case, right? Then start your role by communication to the labor ward in that receiving the hospital, okay? And you are going to explain to them the situation because they have to be ready for her delivery.
Yes.
Right? Okay. So once they agree, both the neonatology team and the obstetric team in the receiving hospital, you will start your
transfer letter.
Transfer letter. Yes, excellent. You have to start your transfer letter after you had your patient to consent. including the written spar.
Mm.
Okay, so you have to have the transfer papers ready with you. Okay, and you will find out who is this courting nurse, okay, or the midwife that she had experience in delivery, and in the same time she had experience of neonatal resuscitation. You suggested that one of the pediatric or the neonatologist nurses will be there, okay, but you have just mentioned that you need a nurse, okay, with she can manage, okay, the
Neonatal
neonatal resuscitation. Yes,
Mm.
don't forget about the in-utero-transfer kit, right?
Mm.
So the kit should be will be ready for the patient,
Mm.
right? And the medications are kept in the fridge. Some of the examiner asked about what type of the medication and where will be the medication.
Mm.
Okay, so the medications will be in the fridge,
Mm.
right? For this patient ready, okay? And so the midwife should not, forget about taking the medication with her. Name the medication and the need for them, okay? And when you mention, for example, okay, you give the patient tucolysis.
Mm.
Please mention what type of tucolysis, okay?
Okay.
So you just mentioned that the patient had received this, okay,
Yeah.
medication. Either it's you want to speak about the nifedipine, you want to speak about the
Steban.
yes, Siban, it's fine,
Mm.
right? Then you go to the point of the steroid, the first dose given, at what time, everything, okay, would be what happened to this patient, all the patient notes, okay, including the medication that she had, will be handed over to the other hospital through the written SPAR, right?
Okay.
If there is any investigation result, or if there is a CTG, okay, so a copy of this, okay, will be attached
Yes.
with the patient, right?
Yeah.
So this is regarding the preparation from your, your side, okay? Here in this part, this is Plymouth Hospital, okay, about the intra-uterine transfer, okay, and here is a very nice, documented to refer to for the arrangement of the transfer, okay. Here they put in the point, okay, first point they have covered the introduction, then the indication, then the contraindication for the in-utero transfer. One of the tasks, okay, I have heard about it, that the patient presented not with PPROM, patient presented with APH, antepartum hemorrhage, okay? So you have to manage this way, okay? For the PPROM, we cover with the antibiotic and all for the, and watch for, or be careful, okay, that this is a breach high risk for cord prolapse as well. But in the antepartum hemorrhage, okay, so we speak about the
Placenta previa and abruption.
yes, the placenta abruption, about the blood product, about that, measuring the patient, the white bore cannulas and all. Okay, so maternal consent here, it's very important about the point of the maternal consent is in management, okay, of the in-utero transfer. So the management, by steps, okay, they ask about it, okay. So here, it's ultimately the responsibility of the obstetric consultant and registrar as well, okay, as whether to, transfer the patient. However, it is expected that the decision should be discussed with the neonatologist prior to the transfer and documented within the patient records. Once the decision has been made to transfer, it is in the referring unit responsibility to arrange a safe and efficient transfer. Okay, here there is an appendix at the end, okay, appendix 4, which will aid, okay, you to memorize the arranging for the in-utero transfer and guide to hospital to contact. Okay, so make sure that there is a cot space in the appropriate unit. Sought firstly by contacting the neonatal consultant on the NICU who receive daily update on the cot availability within the, the network, the trust network. Okay, then what can be done? Okay, on finding the available neonatal cot, the registrar at the referring unit must contact the NICU sister, neonatologist, obstetrician, and labor ward sister at the receiving hospital to gain agreement from all for the transfer. And a SPAR handover, okay, form must be fully completed by the midwifery and medical staff and signed by the obstetric registrar, okay? So the form of handover is very important. This is, again, the hospital-to-hospital communication, right? Photocopy of the obstetric notes, including all relevant test results, should be taken, okay? And the original notes must not be sent, okay?
Yeah.
So if the need of transfer is very urgent, then the helicopter transfer should be considered, okay? So then the arrangement for the transfer by road, ring the ambulance control, okay? The ambulance control will discuss the time scale for the transfer, okay? If it is deemed as an emergency, okay, dial the 999, okay, to state that the category B transfer is required. One of the friends have recalled that the examiner asked which type of ambulance required, okay? So speak about the urgency of the transfer. So arrangement of transfer, okay, by helicopter again, this is for the top urgent cases, okay, and escorting, okay, one appropriately trained midwife who is competent in newborn resuscitation, okay, to provide immediate care to the baby. Some situation may not require a midwife escort, okay, like if this is a planned delivery, but your patient, she
will require
risk of delivery, so you have to send a midwife for her. Okay, in-utero transfer bag on delivery suite should be checked and taken on the transfer and include the symptometrine and syntocinon, which can be found in the fridge. Okay, student midwife must not undertake escort duties. Okay, so prior to the transfer, fetal monitoring should be performed before the transfer, depending on the station and appropriateness. IV access obtained. Consider fetal fibronectin testing if appropriate. However, because the patient is BPROM already, so we will not do it. The assessment, okay, consider use of tocolysis. So according to the unit policy, if there is any time the midwife involved with the transfer of patient has concern, they must inform the coordinator and if necessary, contact the supervisor of midwife for advice. During the transfer, okay, during the journey of the escorting midwife, has a responsibility to continuously assess the patient clinical status as instructed by the obstetrician, and depending on the present clinical picture, tailor the observation required according to any changing clinical need. If in preterm labor observation should be also monitored, including palpitation of the contraction and monitoring of vaginal loss. There is no indication for fetal heart rate auscultation during the transfer. Okay, again, also it came also that some of the examiner asked, will you use the CTG during the monitoring? Okay, during the transfer. All care provided during the transfer should be documented clearly within the notes. Okay, and if at any time during the transfer the midwife feels that the patient's situation is changing or deteriorating or that delivery is imminent, the transfer should be diverted to the nearest hospital with a maternity unit. Okay, so let's say that examiner came to this point, okay, that the patient progressed during the transfer, it should be diverted to the nearest hospital. Okay.
Okay.
So this is the full management of the in-utero transfer, and I would like to thank you very much. Okay, I also pray for you and
Thank you.
I wish for you to pass, inshallah, because you
Sure.
deserve it. Okay.
Thank you.
Thank you very much for your time, my dear, and you know, for giving me the chance to discuss those cases with you, because I feel like there's some cases I want to discuss. Okay, so thank you very much.
No worries. No worries. Thank you. Thanks.
Thank you.